Today, we're diving into a story of medical discovery that's changing how we think about one of the most critical questions in cancer care, knowing if the treatment is actually working. Now, before we jump in, all the credit for this explainer goes to an incredibly insightful review by Dr. Reza Lankarani. He's a general surgeon, the founder of the Surgical Pioneering newsletter and podcast series, and he's on the editorial board at the Genesis Journal of Surgery and Medicine. He did a deep dive on a major meta-analysis from the International Journal of Surgery, and we're here to break down what he found.
So let's start with the central problem, this huge, lingering question that weighs on every patient and every doctor.
I mean, think about it. After months of grueling, aggressive treatment, how do you really truly know if it worked? Is the cancer completely gone, or is there something left behind, something microscopic and invisible to our best scans just waiting to come back? That uncertainty is exactly what this research is trying to solve. And that brings us to the hero of our story today, a revolutionary technology that we call a liquid biopsy. Okay, first, a quick definition so we're all on the same page. Neoadjuvant therapy, or NAT. You can think of this as the opening salvo in the fight. It's the chemotherapy or radiation that's given before the main event, which is usually surgery, all with the goal of shrinking the tumor to make it easier to remove. Now for the tech itself. As tumors grow, they're actually a bit messy. They're constantly shedding these tiny fragments of their genetic code, their DNA, right into the bloodstream. And we call this circulating tumor DNA, or ctDNA for short. The best way to picture this is to think of it like finding the tumor's fingerprints, or maybe a trail of breadcrumbs just floating around in the blood. If you can find those breadcrumbs with a simple blood test, well, then you have a way to track the cancer without doing an invasive biopsy. So having this trail of breadcrumbs is one thing, but the billion-dollar question is, does it actually mean anything? Can it predict a patient's future? To answer that, we have to look at the evidence. And this isn't just one small study. No, this was a huge meta-analysis. That means researchers combined the results from 10 different studies involving over 500 patients with esophageal cancer who had all gone through that neoadjuvant therapy. When you pool that much data, the conclusions carry some serious scientific weight. And here is the crucial discovery. What they found is that when you're using this incredible tool, timing isn't just important, it is everything. It's not about if you test, it's about when you test. Let me show you what I mean. The researchers zeroed in on 3 critical moments to test for this ctDNA. First, right at the start, before any treatment. Second, after that initial round of therapy. And finally, after the tumor was surgically removed. And the first result was a huge surprise. Testing for ctDNA before treatment told them almost nothing. Whether a patient was positive or negative at this stage made no significant difference in their outcome. It was a dead end. But then, look what happens. You test again right after that first round of therapy, and the whole picture changes. Suddenly, the presence of those ctDNA breadcrumbs becomes a powerful, powerful predictor of that patient's future. And I mean really powerful. Patients who still had detectable ctDNA in their blood at this point were nearly 4 times more likely to have their cancer progress. That's not a subtle signal. That is a massive red flag. And after surgery, the signal gets even stronger. For patients who are still ctDNA positive, the risk of progression and the risk of mortality are both over 4 times higher. This confirms that ctDNA is a fantastic marker for what we call minimal residual disease, the tiny cancer cells left behind that are totally invisible to scans. So what does all this data mean for the future of fighting cancer? Well, it essentially gives doctors a brand new map to guide their decisions. The path forward becomes so much clearer. You test for ctDNA after therapy and surgery. If that test comes back positive, it's like a warning flare. That patient is immediately flagged as high risk. And that means doctors can personalize what happens next, maybe with more frequent scans, or even additional therapy to hunt down any leftover cancer cells. So let's just sum it all up. The key takeaway is this. Post-treatment ctDNA is a game changer for predicting survival. It lets us sort patients by risk, which opens the door to truly personalized treatment plans. The next crucial step, of course, is to standardize the tests so this can be used reliably in every clinic, everywhere. And that leaves us with this final, profound thought. We've just seen how a simple blood test, when it's timed perfectly, can give us a crystal clear signal in the chaos of cancer treatment. So the question is no longer just about esophageal cancer. It's about whether this approach could soon redefine how we fight this disease entirely. As a reminder, this explainer was based on a profound review by Dr. Reza Lankarani, who serves as an editorial board member at the Genesis Journal of Surgery and Medicine. To access even more details, please check out the Surgical Pioneering Podcast Series application. The link is right there for you. Thanks for joining me.